Every day you grind through crunches until your core is burning. You've ditched the carbs, tracked every single calorie, cycled through every diet that promised you a flat stomach, and your belly still pushes forward. Let me share something that is going to permanently change the way you understand your own body. 90% of women who live with painful sex, swollen legs, and varicose veins have been told it's genetics, or hormones, or simply the body they were born with. That is incorrect. Completely incorrect. And the real cause, the one no one is talking about, is sitting inside you right now, pressing outward. They won't bring this up at your next routine checkup. The system profits when you keep returning with symptoms, not when you actually heal. Subscribe and hit like if you're ready for the truth. Help Dr. Wilson reach 100 points arrived subscribers. Let me walk you through what is genuinely happening inside your abdomen. Most people stand in front of the mirror, decide they've been eating too much, and conclude that if they simply ate less, the belly would shrink away. I understand that reasoning. I also watch it fail every single day in my clinic, because the anatomy tells an entirely different story. Let's talk about the front abdominal wall, the layers between your skin and your internal organs. Yes, there is a layer of subcutaneous fat there. Subcutaneous fat simply refers to the fat sitting directly beneath the skin. In a lean individual, that layer might measure 2 to 3 cm. In someone carrying significant excess weight, it can reach 10 cm. A 15 cm or a subcutaneous fat layer is extraordinarily uncommon. That would represent end-stage severe obesity. But I see patients every single day whose belly protrudes far beyond what any fat layer could account for. The volume pushing outward is many times greater than subcutaneous fat alone could produce, which means something else is responsible, an internal force pressing that belly forward. We can immediately eliminate pregnancy from the equation. Pregnancy is the one physiological reason a belly is supposed to protrude. A healthy, entirely welcome reason. But if you are not pregnant, the structure pushing your abdominal wall outward is your intestine, your gut. Under normal, healthy conditions, the gastrointestinal tract, your stomach, your intestines, your colon, should sit in a firm, well-supported position inside the abdominal cavity. The ligaments and connective tissue holding everything in place keep your organs lifted and organized. But when those supporting structures weaken, the intestine descends. It drops. Doctors refer to this as visceroptosis, which simply means prolapse or downward displacement of the abdominal organs. Once the intestine drops, it has to go somewhere. The pelvic cavity is not infinitely elastic. It cannot expand to accommodate the shift. So the gut does the only thing available to it. It pushes forward, and your belly protrudes. This is the insight that changes everything. You are not fighting fat. You are fighting gravity. The real challenge is restoring the correct anatomical position of your intestine. When the intestine rises back to where it belongs, it stops pressing outward from the inside. And the belly flattens. Not because you lost weight, but because the mechanical pressure has been removed. I have watched this happen in a tremendous number of patients. They learn one specific exercise. They change absolutely nothing in their diet. Not a single meal, not a single calorie. And within 3 to 4 weeks, their belly visibly tightens and flattens. This works in men and in women. It works in people who are very lean and in people who carry extra weight. The before and after results are genuinely striking, and the timeline is 3 to 4 weeks of daily practice. No starvation, no supplements. Pure mechanical physics. Lifting the intestine back into its correct position. Now let me explain why this matters far beyond how you look in a mirror. Because the consequences of a prolapsed intestine are serious, systemic, and clinically significant. When a heavy, descended intestine sits in the lower abdominal cavity, it acts like a hydraulic press. The major veins that carry blood from your legs, pelvis, and lower abdomen back up toward the heart run directly through that space. Venous blood, the blood that has already delivered its oxygen and needs to return to the heart for recycling, flows upward through those vessels. When a prolapsed intestine compresses those major veins, blood flow backs up. It stagnates. You get a dam effect throughout your entire lower body. What does that look like clinically? You develop heavy, persistent swelling in your legs. You develop progressive varicose veins, the swollen, twisted, visible veins that bulge beneath the skin of your calves and thighs. You develop hemorrhoidal vein enlargement. Hemorrhoids are essentially varicose veins of the rectum, and the same venous stagnation drives them. In women, the uterus becomes congested with blood because venous outflow from the pelvic organs is obstructed. That congestion directly causes abnormally heavy, prolonged menstrual periods, lasting 5 to 7 days instead of the normal 3 to 4, with excessive flow that leaves you completely drained. The problems continue. The descended intestine rests its full weight directly on the bladder. That pressure manifests as urinary urgency, the constant sensation that you need to go. It causes nocturia, meaning you wake up multiple times during the night to urinate. It causes stress urinary incontinence, meaning you leak urine when you cough, sneeze, laugh, or exercise. These symptoms are dismissed so often as just getting older, or just a consequence of having had children. They are neither. They are mechanical consequences of a displaced organ. In women, when the prolapsed intestine presses on the uterus physically shifts out of its correct position. When the uterus tilts or displaces, penetration during intercourse creates traumatic, too close contact between the partner and the cervix. The cervix, the lower opening of the uterus, is a highly sensitive structure that, when impacted directly, causes sharp, significant pain. 90% of cases of painful intercourse in women are connected to this exact mechanism. Organ prolapse, not psychological issues, not inadequate lubrication, not simply heightened sensitivity. 90%. That number should cause every gynecologist to stop and reconsider what they are telling their patients. And the intestine itself suffers when displaced downward and compressed under its own weight. Its function deteriorates. Transit slows and you develop chronic constipation. Difficult, infrequent bowel movements that leave you uncomfortable and bloated. You develop persistent abdominal bloating, the constant sense that your belly is distended and full of gas. You experience ongoing discomfort after meals, and a compressed, poorly circulating intestine becomes a more hospitable environment for pathogens. Inflammation develops more readily. Parasitic infections take hold more easily, further impairing digestive function. Now here's the clinical reversal, and this is the part I want you to focus on completely because this is what 15 years of watching patients recover actually looks like. When we mechanically lift the intestine back into its correct anatomical position, the improvements are fast and they are real. Varicose vein progression halts. Leg swelling visibly reduces. Patients stop waking during the night to urinate. The nocturia resolves. Stress incontinence disappears. Menstrual periods that previously ran 5 to 7 days normalize to 3 to 4, with dramatically reduced flow. The quality of intimate life improves markedly. Constipation and chronic bloating that patients had endured for years clear up entirely. One exercise, one repositioning, a cascade of improvements across the entire lower body. The reason all of this is achievable is purely anatomical. Remove the mechanical compression, lift the intestine, and the dammed blood flows freely again. The bladder is no longer under pressure. The uterus returns to its natural position. The gut regains normal circulation and function. You are not treating 10 separate conditions. You are correcting one structural problem. For the most complete and fastest results, the approach needs to be comprehensive. The organ lifting exercise needs to be combined with strengthening of the abdominal muscles and the pelvic floor. The muscles of the perineum, which form the hammock-like base of the pelvis. The involvement of a nutritionist and an endocrinologist is also important, because ligament and connective tissue weakness, the structural failures that allowed the intestine to drop in the first place, often have metabolic and hormonal roots. Collagen synthesis, the process your body uses to build and repair ligaments, depends on specific nutrients and hormones. Addressing those deficiencies accelerates and sustains the recovery. Now let me give you the exercise itself. Follow this carefully. It has 3 precise sequential components. Each part must be executed fully or you will not achieve the result. Part 1. Exhale completely. Force every last bit of air out of your lungs. Compress your chest. Empty yourself entirely. Do not stop halfway. Drive the exhale to its absolute end. Part 2. Hold your breath at that full exhale. No air in the lungs. In that moment of breath hold, draw your abdomen inward as forcefully and as deeply as you possibly can. The goal is to create a deep hollow just below your rib cage, a visible concavity where your belly normally protrudes. Pull it in as far as it will go. Part 3. Bring the fingertips of both hands together flat, like a spatula or a wedge. Starting from the pubic bone, the hard bone at the very base of your abdomen, use those gathered fingertips to physically lift the abdominal tissue upward, dragging slowly and firmly all the way to the navel. When you have completed that upward stroke, release the tissue gently back to its resting position. Only then, slowly through your nose, inhale. Everything is slow. Everything is smooth. No jerking movements, no rushing. The moment you rush, you lose the therapeutic effect. The lift must be deliberate and complete, from the pubic bone all the way to the navel, with firm, steady pressure. The most common mistake I see is half effort. People breathe out a little, they draw their stomach in a little. They barely make contact with their own body. That does nothing. The exhale must be maximal. The abdominal draw-in must be maximal. The manual lift must be firm and intentional. If you reach the point where you feel a mild urgency for air, that is correct. That is the signal that your lungs are fully emptied and the exercise is working. I have never seen a single patient execute this perfectly on their first attempt. That is completely normal. With daily repetition, the technique improves, the capacity deepens, and as a secondary benefit, you are also developing meaningful respiratory muscle strength. Your diaphragm and the accessory muscles of breathing receive a genuine workout. Some people are concerned they might injure themselves by pressing on their abdomen. Let me address that directly as your physician. You cannot harm yourself. Finger pressure applied manually to your own belly cannot penetrate skin, subcutaneous tissue, the dense fascial layer called the aponeurosis, essentially a thick sheet of connective tissue reinforcing the abdominal wall, and then the muscles and the peritoneum beneath it. The peritoneum is the membrane lining the inside of the abdominal cavity. To actually damage an organ, you would need a level of force that is simply impossible to generate with your own hands. If you feel discomfort anywhere, you instinctively ease the pressure. Your nervous system handles that automatically. The same reassurance applies if you have had a surgical incision. If more than 1 month has passed since a cesarean section or any other lower abdominal surgery, your scar is fully formed and structurally sound. You will not damage it. In fact, lifting the abdominal tissue after a surgical incision carries an additional benefit. It stretches internal adhesions, bands of scar tissue that form inside the abdominal cavity after surgery, which can tether organs, restrict movement, and impair bowel function. Manually lifting and mobilizing the tissue helps free those adhesions, which can significantly improve intestinal function in post-surgical patients. How often should you do this? At minimum, 2 to 3 complete cycles before sleep each night, meaning 2 to 3 full repetitions of the exhale, draw in, and lift sequence. For faster results, add a morning session. For even faster results, practice 3 times daily. 1 year of consistent daily practice is the time frame for a stable, lasting result. The ligaments that hold the intestine in position are slow to rebuild. They do not recover in weeks. They need months of sustained mechanical loading and nutritional support to regain their holding strength. The one exception: during menstruation, stop. Take those days off. Your uterus is actively contracting and shedding its lining during that window. This is not the right time to add mechanical stress to the pelvic structures. Expect some mild abdominal soreness after your first few sessions. That soreness is physiologically normal. When you lift a prolapsed intestine, you restore blood flow to tissues that have been chronically underperfused, meaning blood has not been adequately reaching them for a prolonged period. Newly restored circulation triggers an inflammatory response in those tissues, which presents as a dull ache. It passes. It is your body coming back to life. Women may also notice some changes to their next menstrual cycle. It may arrive slightly earlier than expected. The flow may be heavier or lighter than your baseline. In rare cases, there may be light spotting between cycles unrelated to menstruation. This occurs because the repositioned uterus now has different circulatory dynamics, and the endometrium, the inner lining of the uterus that sheds during menstruation, adjusts to the new blood supply. This is not a warning sign, but if it concerns you, a visit to your gynecologist will confirm that everything is progressing normally. Here is the long-term picture. This is not a 30-day challenge you complete and put behind you. Gravity acts on your body every second of every day. Every time you lift something heavy, run, jump, or simply stand upright for hours, gravitational load is pulling your visceral organs downward. If you want a healthy, youthful face, you maintain it continuously. Skincare, protection, hydration. Your intestine deserves the same logic. 2 minutes a day to mechanically maintain the position of your organs is not an inconvenience. It is basic anatomical upkeep. After approximately 1 year of committed daily practice, even severe prolapse is corrected. The acute phase is resolved and the worst symptoms are eliminated. That change is visible and measurable. After that first year, the daily practice shifts from rehabilitation to maintenance. And that is a considerably lighter task. Now, one clinical observation that relates directly to your age, because this matters for how urgently you should act on this. Ligament strength and connective tissue integrity decline measurably after the age of 40. The supporting structures that hold your abdominal organs in their correct position are made of collagen, and collagen synthesis slows significantly with each decade past 40. Visceroptosis progresses faster in people over 40 simply because the tissues responsible for holding everything in place are weaker and slower to regenerate. How old are you? Write your age in the comments. I want to understand where our viewers fall on that risk curve, because the answer shapes how strongly I recommend starting this today. Here's your clear, practical takeaway. Stop fighting your belly with AB crunches and calorie restriction. That is the wrong battle entirely. The target is your intestinal position, not your fat layer. Start the 3-part exercise tonight. Full exhale, maximum abdominal draw-in with a breath hold. Slow manual lift from the pubic bone to the navel using gathered fingertips. 2 to 3 cycles before sleep. Add a morning session if you want faster progress. Stay consistent for 1 year. If you have had abdominal surgery more than 1 month ago, do not skip this. Do it. If you are menstruating, take those days off. Monitor your symptoms, the leg swelling, the sleep interruptions, the menstrual duration, the digestive comfort. You will see changes within 3 to 4 weeks. Real, measurable changes. Not because of willpower or a stricter diet, but because you corrected a structural, mechanical problem that was generating the majority of your symptoms in the first place. I'm Sam Waterling, and I've spent 15 years watching patients suffer from conditions that had a clear anatomical explanation and a straightforward solution, while the medical system charged them for treatments that never once addressed the root cause. No one in a white coat at a fee-for-service clinic is going to hand you this information. It doesn't generate a billing code. The truth is free, but only if someone is willing to say it out loud. Subscribe, hit like, and help this channel reach 100,000 subscribers.